is what we have planned out for today. So it's a 1 hour session. Let us see how many questions we are able to do from 8 to 9 p.m. Okay. Okay, let's start then. And do also remember that there's an offer that is going on till tomorrow only, July 15th. It's a combo plan for 13,499. Here you get all the app features plus also a hard copy notes set. You get access to all the app features plus as well as the hard copy notes set as well. Core features of Auricle, you might be aware, we have the recorded live classes as well as the notes and all other features over here. Even the CPME curriculum is also present over here. Okay, fair enough. Let us see the next one. Right. So let us start the session over here. Okay, so this is the first question. It's a mixed bag. We'll start with the upper limb, right? And then we'll move on to other aspects as well. Just a second. Okay. Let me just pick out the pen over here. Right. Okay. So question says that a patient presents with a mid-shaft fracture of the humerus. Okay, mid-shaft fracture of the humerus. Which nerve is most likely to be injured? This is the question. I hope you can see the question. If I may enlarge it a bit, the pen is not working in mere enlargement. Okay. Okay. So let us read out the question. Then when I will write, I will just minimize it to a bit so that we can annotate the notes over here. Yeah. So coming back to the question, a patient presents with a mid-shaft fracture of the humerus. Which nerve is most likely to be injured? Median nerve, ulnar nerve, radial nerve, or axillary nerve. So these are the four options. Which nerve is related to the mid shaft of the humerus over here? And if we go down, we can actually see the answer that is showing as the path of the radial nerve over here. So basically, the answer is radial nerve. No doubt about it. The answer is radial nerve. And here you can see the path of radial nerve. And let us understand how the answer is radial nerve over here. For that, we need to understand that suppose we take this as the humerus, the head of the humerus, right? A bit of neck and a bit of shaft over here. And these are the inferior part of the humerus. Suppose this is the right side humerus, medial side this, lateral side is this. Okay. Now, if we move from this side, right? If we move from this side, we will understand few other things. So let me just move this a bit to change the color. Yeah, now it is good. So yes, coming to the nerves, remember that there are three nerves which are related to the humerus. What are those? Around the surgical neck of humerus, we have the nerve that is the axillary nerve. Which nerve? Axillary nerve. Right? Around the mid shaft going behind in the radial group, the nerve over there is the radial nerve. And therefore, we have seen that that is the answer over here. The third nerve, which goes behind the medial epicondyle of the humerus, can you think which nerve it is? It is the ulnar nerve. So now, depending on what is the question, it's in this question they're asking nerve related to the mid shaft fracture of the humerus. Answer is undoubtedly radial nerve without a piece of doubt. If they would have asked that this is fracture around the neck of humerus, this region is around the surgical neck of humerus, then start thinking of the axillary nerve. And if they say, okay, there's a problem in the elbow on the medial side, there's a fracture of the medial epicondyle over here, then think of the ulnar nerve. This is how you can, right? This is showing us the path of the radial nerve over here. I hope the point is clear. So there are three nerves which are related to the core bone, that is the humerus. Three nerves are related to it. These are the three nerves. It doesn't mean the other nerves cannot be involved. Yes, they can be involved, but not indirectly related to the bony structure. For bony structure, it is our radial nerve, ulnar, and the axillary nerve at the neck. This is the whole point. Okay, let us see the next question. Second question over here. A young athlete falls and sustains an anterior dislocation of the shoulder. We should know that shoulder joint is one of the most commonly dislocated joints. So there is an anterior dislocation of the shoulder. Fair enough. Which structure is most likely to be damaged? That is the question. Let us see other options over here. Okay. Okay. Right. So here are your options. Options over here are four options. First option is glenoid labrum, glenoid fossa, and we have a fibrocartilage around it. So there the question was the dislocation of shoulder, which organ or which structure is most likely injured. Second option is rotator cuff muscles. Third option is coracoclavicular ligament. And the fourth option is the bone itself, that is a clavicle. What do you think? What would be the answer? Again, the question is, there is dislocation of the shoulder. Dislocation of the shoulder joint is there. So as you can see the image below, here, what is being shown as the shoulder joint, which has been removed, but the two bones are separated. So what you are seeing over here is the head of the humerus over here, and this is the glenoid fossa over here. So if there is a dislocation, normally this head of the humerus is fixed to this glenoid fossa. So normally if there is dislocation, anti-dislocation, then you can see this lip over here. These are the lips of the glenoid fossa, that is known as glenoid labrum. So if there's anti-dislocation, then obviously what is going to happen? First of all, there's going to be an injury to the glenoid labrum, because labrum is actually holding the head of the humerus, right? So if the head of the humerus is dislocating, it has to somehow increase its force, which increases or which goes beyond the resistive force of the labrum. So obviously labrum will be the first structure to have some anatomical changes, have some injury. Only then there can be a dislocation. Therefore, the answer over here is going to be what? Is going to be the glenoid labrum, option number first over here will be our answer, right? So let me use this point over here. So answer is what? Answer is the glenoid labrum. Look at the other options. Rotator cuff muscles are the muscles which are actually covering the whole joint from outside. Here you have four muscles. You have S, I, small t, and S. What are those four muscles? Supraspinatus, infraspinatus, teres minor, and subscapularis. These are also known as musculotendinous cuff. What are they known as? They are known as musculotendinous cuff, right? So they are like a protection to the shoulder joint on the outside. Coracoclavicular ligament is also good, but understand in this image itself, this will be the position of the clavicle. Okay, let me make it a bit slowly. Okay, fine. But this ligament over here is between the coracoid process and the clavicle above, because this ligament will be like this. So it is not related directly to the shoulder joint per se. And finally, clavicle is a totally different. So in this question, we have to take the answer as a glenoid labrum. Okay, answer will be glenoid labrum. Let us see the next question. Let me enlarge it a bit. Yes, I hope you can see it well now. A patient sustains a fracture of the scaphoid bone in the wrist. The scaphoid bone is one of the carpals. Okay, in the proximal row, it is the lateral most bone, the scaphoid bone. So there is a fracture of the scaphoid bone. Which complication is most commonly associated with this type of fracture? First of all, let me tell you, out of all the 8 carpals we have, including the pisiform, that is sesamoid bone, one of the most commonly fractured carpal is scaphoid. Fair enough. If a scaphoid is fractured, then one of the most common complications is one of these 4 options: carpal tunnel syndrome, avascular necrosis, median nerve injury, or extensor tendon rupture. These are the 4 options. Answer over here will be, let us see. Let me minimize it so that we can try to draw over here. So imagine this is the scaphoid bone over here, right? Is a scaphoid bone. Okay. Let's forget about the horizontal lines which are going. Now, suppose there is a fracture over here. Now, the main point in the scaphoid bone which you have to understand is the peculiarity is that the blood flow is from distal to proximal. It is in this direction, distal to proximal. So whenever there is any fracture in the scaphoid bone, the proximal region, let me try to show you that suppose this is the proximal region over. The proximal region over here is the one that is more prone to get decreased blood supply if that artery is stopped or injured in that fracture. That is known as your non-union, or it is due to the ischemia, that is decreased blood supply, leading to avascular necrosis. This option B is already highlighted. Avascular necrosis of the proximal segment. So understand that there will be what? There will be avascular necrosis of the proximal segment. Do remember, the more proximal the fracture line is, more chances are there that the proximal segment will be devoid of blood supply. There will be avascular necrosis. It is not that common that, okay, all the scaphoid bone fractures will develop avascular necrosis, not like that. But yeah, it's still 20-30% cases. That is indeed quite a big number. Might develop avascular necrosis. Coming to other options, option A, carpal tunnel syndrome. It is due to the compression of the median nerve inside the or deep to the flexor retinaculum of the wrist. Median nerve injury itself, they are saying, median nerve passes through the or deep to the flexor retinaculum, but it is right in the center, and the scaphoid bone is a bit on the lateral aspect. So yeah, if you also think about the median nerve being right over the scaphoid bone, it is not like that. The scaphoid bone is a bit lateral to the median nerve. And extensor tendons will run on the dorsal aspect. They are not ones which are commonly involved, right? So answer over here will be avascular necrosis. Okay, let us see an X-ray over here. It is beautifully shown. You can see there's an X-ray of the wrist region mainly. And here identify the scaphoid bone and identify the fracture. Now let me highlight this bone over here. Can you see this? These are the forearm bones. The one bone over here, which bone is this? Is this radius or ulna? Think about it. The one where I am, this moving my cursor around over here. This is the radius. So this is the lateral aspect. This is the lateral aspect. The lower end of radius is broader. So this is radius, that is ulna. So looking at a proximal row, this row, here you have the mnemonics, like she looks too pretty. This is the scaphoid bone. Okay. Now this is not a lunate. This whole is a scaphoid bone. And here you can see the fracture of the scaphoid bone. Lunate is this over here. So scaphoid and lunate are directly articulating with the lower end of radius. This is scaphoid and lunate. Triquetrum is this bone over here. Sir, where is pisiform? Pisiform is a sesamoid bone which sits over the triquetrum. Very small PEA, mutter ki, like mutter. Okay, peas. Pisiform is sitting over here. So this is a scaphoid, and here you're seeing the fracture of the scaphoid. So this part of the scaphoid, this proximal part of the scaphoid is at risk to develop. Is at risk. I'm not saying it will, but it is definitely at risk to develop avascular necrosis. If you look at the distal segment, this is trapezium. This one is trapezoid. This largest carpal, which one is this? That is capitate. And this with the hook over here, that is the hamate bone. This is your first metacarpal, second, third, fourth, and fifth. Okay, so this is how you can see the fracture of the scaphoid as well. Let us see the next one. Okay, another fracture question. An elderly patient falls on an outstretched hand and presents with a dinner fork deformity of the wrist. So there is a dinner fork deformity. What type of fracture is this characteristic of? Normally, when you study orthopedics, then it is a case that is shown to you. Even you can see in OPDs and X-rays a lot. But yeah, in first years, at least understand that whenever they ask for the dinner fork deformity, right, it is known as Colles fracture. Colles fracture, where you have the distal part of you have the radius fracture, obviously lower end, but the distal segment goes dorsally, goes posteriorly, giving us a dinner fork deformity. Let us see, first of all, then we'll understand. Okay. So here you see the Colles fracture over here. This distal segment of the fracture goes posteriorly, that is, goes dorsally. It gives off a dinner fork-like deformity. Like when you place a dinner fork upside down, it gives that sort of deformity. This is known as Colles fracture. And why Colles fracture is so common? It is mainly seen in post-menopausal ladies having osteoporosis. Colles fracture, falling on an outstretched hand, then there can be osteoporosis-related fractures in the hip region, can be in the spine region. But yeah, Colles fracture is one of the most common fractures. Smith fracture is just the opposite of Colles fracture, understand? And this Galeazzi and Monteggia, they are also the fracture of the forearm bones, but they are associated with the dislocation of the other forearm. For example, Galeazzi's fracture of radius and Monteggia's fracture of the ulna, but with the dislocation of the radius. Okay, those are different things. But here a dinner fork deformity, ever the question comes, and undoubtedly go with the Colles fracture over here. Colles fracture, and it is one of the most common fractures also seen, right? So remember this part as well. Fair enough. Okay, so answer for here will be, let me highlight this Colles fracture. Fair enough. Let's see the next one, coming to the lower limb now. Okay, let us enlarge it a bit. Okay. Look at the question. A patient is diagnosed with a pelvic fracture involving the acetabulum. What is acetabulum? Same as glenoid fossa was there in the shoulder. We have acetabulum, a concavity in the hip bone. So there's a fracture involving acetabulum. Which movement is most likely to be painful? A very, you can say, sort of logical sort of question we can say. Let us see the options. Flexion of the hip, extension of the knee, abduction of the hip, flexion of the knee. Now see, in these four options, the problem is in the acetabulum. So which joint? It is a hip joint. So we can easily rule out options number B and D. That is extension of the knee and flexion of the knee. Extension and flexion of the knee are done at the knee joint. So we are left with only two options now. First and third option, flexion and abduction of the hip. Here you have to judge yourself that in these two options, which movement involves more of the acetabulum involvement than the other one. Although both will involve, no doubt about it. But abduction of the hip, option number C, it involves more of the involvement where the whole femur with the lower limb is going outside. So there's a whole rotation of the head of the femur inside the acetabulum. Flexion also there's movement, but a bit of less compared to the range of movement in the abduction. So answer over here will be abduction of the hip. Let me show you the acetabulum over here with the head of femur over here. This is the head of femur over this acetabulum. Abduction is going, entire limb is going outside. This whole rotation in this direction, in upward to low, downward direction in the femoral head. Answer over here will be the abduction of the hip, slightly more than the flexion of the hip. Let me just highlight this abduction of the hip over here. Okay, and we can easily rule out what? We should easily rule out with using our common sense only option number B and option number D. We are left with A and C. So you can say, okay, C has more chances than A in this particular question. Simple as that. Both are involving the hip joint. Let us see the next one. Okay, let me enlarge it. And here you go. A young athlete presents with a pain in the anterior compartment of the leg. Pain where? In the anterior compartment of the leg. Simple pain. No other history given over here. While you should know that whenever a patient comes to you with a pain, you have to take a proper history for when it started, how is the pain, when does it occur, what are the aggravating factors, how is the lot of things to be asked in the pain, exactly which side are the associated features with it, and sort of lot of questions. But in MCQ, they are only saying pain in the anterior compartment and a young athlete. After extensive running, after a lot of running, which condition is most likely? Is it compartment syndrome? Is it Achilles tendonitis? Is it plantar fasciitis, or is it a stress fracture of the tibia? Now, if you look at the question over here, let me minimize it a bit so that we can write also a few things. Achilles tendonitis is what? What is Achilles tendon? It is the tendon of the posterior compartment of the leg region. You know, tendocalcaneus that goes to the calcaneum bone. That is present in the posterior region, not the anterior. So you can rule out option number B. Plantar fasciitis is a problem of the sole of foot. Problem of the sole of foot. Here they are saying anterior compartment of the leg. Now, anterior compartment of the leg, yeah, can have both of these two things like option number A and option number D, having compartment syndrome as well as stress fracture of the tibia. But after a lot of running and all, extensive running, young athlete, both of them can be there. The only difference over here is that a stress fracture tibia will be, pain will be at a specific location, because here you are having the fracture. Here you are having the fracture, specific location, point tenderness will be there. And also there has to be obviously some, this deficiency of vitamin E and calcium and other things should be there. While in case of compartment syndrome, it is due to when it is increase of your pressure, intra-compartmental pressure more than 30 millimeter mercury. This is also commonly seen. This is also commonly seen over here. So here we can go with again another point that A is having more chances than option number D. Compartment syndrome could be most likely the answer over here. Though, let me be honest, if expand the question, if it is a total more clinical based question, then things could have been more better. But yeah, out of these two options, we can go with compartment syndrome. Okay, let us see the next one. A patient presents with a fracture of the neck of femur. Okay, which artery is most likely to be at risk of damage, potentially leading to avascular necrosis? Again, avascular necrosis. Now see what happens. Fracture is where? At the neck of femur. So when there is fracture at this site, which part will develop avascular necrosis? It is the head of femur. So there has to be arteries which are going from neck to the head. So if those are injured, the head will develop avascular necrosis, and that leads to your hip joint to complete replacement, right? Let us try to understand over here. So if we try to draw over here, what? We try to draw the upper end of the femur, look at the rounded head and the neck over here and the trochanterus over here, right? Now what happens is this is the fracture site. This is the fracture site at the neck of the femur. We also have to understand that what is actually happening is that your arteries are going in this direction, Now you have to choose which artery. Is it obturator artery, femoral artery, LCFA or MCFA? What is LCFA, MCFA? Lateral circumflex femoral artery and medial circumflex femoral artery. Coming to the first and second options, they are obviously you can easily rule them out because obturator artery is coming from the medial aspect. Okay, it is not at the neck of femur. Femoral artery is a huge artery running anteriorly in the anterior compartment of the thigh. And then it will give up profunda femoris artery, which will give up the circumflex femoral. So you can easily rule out option number A and option number B. Now you're left with these two options, circumflex, femoral, lateral, and medial. Both of them will be at the neck of femur and they are going towards the head of the femur. Fair enough. Which one to choose? Out of these two, lateral, medial, circumflex, femoral artery, the main artery which supplies the head of the femur is our medial circumflex femoral artery. So even if the LCFA is injured, it might not lead to avascular necrosis because MCFA, medial one, is the one that is giving the main blood supply to the head of femur. This is the reason why MCFA will be the answer. And here we can, just a second, here we can see an image over here. Have a look at this image also. This is showing us the anterior posterior views. And here this region is the neck of the femur. And here you can see all these circumflex femoral arteries. All these circumflex femoral arteries. This one is the lateral circumflex. Going behind is the medial circumflex. This is a posterior. You can see this whole medial circumflex femoral artery giving off branches going to the head of femur. So if you have a fracture over here, and all these retinacular branches, we call them as, they might be blocked, and obviously there's be less blood supply in this area, leading to avascular necrosis, or to be simple, leading to death of the tissue in the head of femur. Simple as that. Okay, let us see the next one. Okay, football player suffers a blow to the lateral aspect of the knee, outside of the knee, resulting in injury to the structure within the knee joint. Obviously, football, I mean, so who are football fans right now? These days, Euro Cup is going on, right? And if I'm not wrong, we have a final tonight, right? If you are a football fan, soccer fan. So if there is a injury to the outside of the knee, and you know, you have seen the game, how common it is, and there's a severe injury in that part, and there's some injury inside the knee joint, which ligament is most likely to be injured? That is the question. Is it ACL, PCL, or collateral ligament? Is it one of the cruciate ligaments or one of the collateral ligaments? That is the question. Here we have to understand the anatomy of the knee joint, then we'll understand it better. So looking in the anatomy of the knee joint, let us see if we have an image over here. If not, then just a second. Yeah. Okay, here you can see at the image. I guess that will be better for an understanding. Okay. Fair enough. So again, anterior posterior views. Now try to understand. Which bone is this? This is fibula, this is tibia. This is the outside. This is the outside part. That is the medial part, inside. So for this diagram, anterior view, front view, this is the lateral, this is the medial side. So injury happened on the outside part. Okay, over here. The options given are two cruciate ligaments. Now these, can you see this crossing ligaments? Very strong ligaments on the deep inside of the knee joint. These are cruciate, anterior and posterior cruciate ligaments. While knee joint being a hinge joint, you will have collateral ligaments. On the medial side, having the medial collateral ligament, also known as tibial collateral. On the outside, we have the lateral collateral ligament, also known as fibular collateral ligament. These support the knee joint from the outside, and the cruciate are at the inside. Simple as that. Main four ligaments are these, and then we have two menisci also, which are also commonly teared. Now, injury happened over here. Obviously, joint will move in which direction? Suppose by these two hands, this is the femur, that is the tibia, right? Imagine it to be the knee joint. Injury happened from here, outside, lateral side. Joint will move like this. Yes or no? It will move like this. So which ligament is stretching inside? Forget about the cruciate. Cruciate, there won't be much of a damage. Cruciate is injured when there is a rotational injury. Then the cruciates are injured. In this lateral force, it is the collateral ligament that will be injured. So if you apply the common sense, then you can rule out the two options of cruciate ligament. Now we are left with two collaterals. So if there's outside injury, the knee will go like this. Stretching will be on the medial collateral ligament or the tibial collateral ligament. Can be there can be injury to the medial collateral ligament. Same thing happens in our ankle sprain as well. In inversion injuries, normally ankle has an inversion sprain. It is the lateral ligament, right? The talofibular ligament, they are the ones which are injured because they on that side there's more of stretching. Because ankle and knee both are hinge joints. Answer will be logical answer will be the medial collateral ligament. Let us see if we have an option like that. Yes, option number C over here, medial collateral ligament will be your best possible bet over here. And as I told you also, try to understand how we can rule out the options. That is also very important. Rule out cruciate ligament. They are involved basically in rotation injuries. Much important force is needed, right? And if they tomorrow they ask you, okay, medial collateral ligament, if it is injured, can there be any other associated injury with the medial collateral ligament? The answer is yes. Which is that structure? That structure is medial meniscus. Medial meniscus is actually fused, sort of fused to the medial collateral ligament. So if the medial collateral ligament is injured, then there are good chances that the medial meniscus will also be injured. Where is medial meniscus, sir? Let me show you. This over here is the medial meniscus. Can you see this medial meniscus? It is attached to the medial collateral ligament. This is a medial meniscus. This is medial collateral ligament. Okay. Let us see the question on the thorax part also. Okay, here you go. During a thoracic surgery, a surgeon accidentally damages a nerve running close to the rib cage. There can be damage to nerves, but look at the next line. Which nerve is likely to be injured, causing paralysis of the diaphragm on one side? What does it mean? It means that that nerve has to give motor supply to the diaphragm. Yes or no? Only then there will be a paralysis of the diaphragm. The only nerve that gives motor supply to diaphragm, I am using the word only and motor. I'm not saying sensory, no. There are many nerves which might give sensory supply to diaphragm. But giving motor supply to diaphragm, there's only one nerve. And that is our phrenic, P-H-R-E-N-I-C, option number B over here. Without a single piece of doubt. So answer over here will be what? Will be option number B, phrenic nerve. Okay, let me show an image over here. Okay, here you go. Let us see this image. Okay. Phrenic nerve, what is the root value? It comes from the cervical region. C3, C4, C5. Main root value is C4. Then it goes down, 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 down between the heart and the lungs. It goes down and it gives motor supply to diaphragm. So if any one side phrenic nerve is damaged, that side diaphragm will be paralyzed. It leads to hemidiaphragm. And what happens in this? There is paradoxical movement of the diaphragm in inspiration, expiration. Normally what happens? When we inhale, during inspiration, the diaphragm goes down. It contracts and goes down. In this situation, suppose the right side of the diaphragm is paralyzed. When the person will inhale, this muscle will not work. So the left side of the diaphragm will go down. And as there is a fixed abdominal cavity pressure, as the left diaphragm will go down, it will push the right diaphragm upward. So that is known as paradoxical movement of diaphragm in paralysis, right? So remember that, right? So answer there will be obviously phrenic nerve without a doubt, having the root values of C3, C4, C5, right? So let us just highlight this answer as well over here. Answer over here is our phrenic nerve, option number B over here. Look at the other options, the intercostal nerve. Intercostal nerve is same as your thoracic spinal nerve. Okay. They might be sensory, they not might, but they are sensory to the diaphragm, but they are not motor to the diaphragm. Third option is vagus nerve, nothing to do with the diaphragm. Fourth option, sympathetic trunk, is sympathetic. So that is also nothing to do with the motor supply of diaphragm. Okay, let us see the next question of thorax. A patient involved in a car accident sustains a fracture of the sternum. Okay, so patient involved in a car accident has fracture of the sternum, front bone over there. Which of the following structure is least likely to be directly affected by this injury? So you have to understand out of 4 options, apply common sense also, which structure is least affected by the damage to the sternum. Is it heart, lungs, aorta, or stomach? Think about. Okay. So think about the options, the organs, the structures which are very close to sternum. So obviously they might be affected. And out of these 4 options, which one is farthest from the sternum? That will be our answer. So looking at the option heart, just behind the sternum, we have the pericardium and having the heart. So heart can easily be involved. You can understand while doing open heart operations, we have to cut through the sternum, then we do an open heart surgery. Heart is just behind the sternum. Second option, lungs again. The pleura run very close to the sternal border. If you look at the pleural reflection, it runs very close. So if there's a sternum fracture, it might lead to pleura or lung damage, obviously. Aorta. Is aorta involved? If heart is involved, aorta is involved. Sure. But couldn't be possibly, but yes, it is. We'll see. Sternum has 3 parts. The upper part is known as manubrium sternum, right? Behind the manubrium sternum, we have the arch of aorta. You can't palpate it because it is behind the sternum, but it is right behind the sternum, the arch of aorta. The stomach lies in the abdominal cavity, first of all. Second thing is stomach is actually covered by liver. Let me show you a diagram over here. Don't worry about it. Therefore, answer will be the stomach. Look at these 2 images over here. First of all, look at these 2 images. This is what they are showing as the sternum over here. This is the sternum. This is the manubrium part of sternum. This is the body of sternum. So heart lies right over here, this whole region. If I try to make the outline of the heart outline will be somewhat like this. Pericardium including. And pleural reflection goes around over here. There's apex, so lungs. Aorta. Now think over here. This is where the ascending aorta lies exactly. And then there is an arch of aorta which goes from front to back, right behind over here. Now where is stomach? The stomach is right over here and going down into the abdominal cavities. Plus, it is more deep. Let me show you a separate image over here. This you will understand better. This is the lateral view. On the left side, this is the anterior aspect. On the right side, this is the posterior aspect. You can see the vertebral column as well. So you can see right behind the sternum. This over here is the sternum. Can you see the sternal angle written over here? Manubrium. Right? This all is sternum. So you can see the heart, and on both sides of the heart, you have the lungs. This is the aorta over here. Right behind the manubrium, what we have, as I told you, this is the aorta. What is this? It's just the thymus over here. But this is the aorta. Where is stomach? Now, can you see this tube over here? This is the esophagus. So where will be stomach? Will be over here. How far it is from the sternum? Which organ will be over here? Mainly liver. Liver will be over here, and this will be the region of the stomach over here. This will be the liver. Okay, so it is, the stomach is quite far behind the sternum. Therefore, answer will be our stomach only. So let us highlight that part of the stomach. Okay, so let us highlight this stomach. I hope you're getting the point. Okay, let us see the next question. A patient involved in a high-speed motor vehicle accident presents with multiple rib fractures and paradoxical movement of the chest wall during respiration. Again, when the word paradoxical movement comes, it means that during inhalation, what happens is our rib cage is expanded because air is coming, right? So rib cage expands both in AP diameter as well as transverse diameter. And the paradoxical movement means that during inspiration, the rib cage is going inside, and during expiration, it is coming outside. That is paradoxical, same as we discussed in case of diaphragm. So there's a high-speed accident, multiple rib fractures, leading to the paradoxical movement. What is this condition? This is by definition known as flail chest. What is that known as? It is known as flail chest. F-A-F-L-A-I-L. This over here, without a piece of doubt, undoubtedly go with option number C, flail chest. That gives rise to your paradoxical movement, having multiple rib fracture. And here you have to see the definition of the flail chest. When we use the term multiple rib fractures, it does not mean that, okay, there are 4 rib fractures, but one is the right second rib, other is right fifth rib, other is left third rib. No, they have to be consecutive. They have to be in line with each other, aligned to each other. Like there's right second rib, then right third, right fourth, right fifth, like this. Okay. It has to be consecutive. That is the main point over here. Only then it will involve that whole segment. That whole segment will become flail segment as given this diagram over here. You can see the paradoxical movement during inspiration, during expiration, paradoxical movement. Arrow is going over here, and this air is actually sucked inside. So this paradoxical movement in the multiple rib, they are consecutively fractured. Tension pneumothorax, option number D is a different one. That is actually an emergency situation. Where with each cycle of respiration, more air is actually coming into the pleural cavity, not the lungs. So in tension pneumothorax is what? Air in the pleural cavity. Upper two options, first and second, pneumo and hemothorax, are air and blood in the pleural cavity. Tension pneumothorax is rapid involvement of air inside the pleural cavity. Now, that air will be pushing the lungs. So with each cycle of respiration, there will be more problem in breathing. But here, paradoxical movement answer is undoubtedly our option number C, that is the flail chest over here. Flail chest over here. Okay. Let us see the next question. A patient with a history of severe COPD, chronic obstructive pulmonary disease, normally seen in chronic smokers, asthma. Okay, asthma, some people say it is correct word is asthma. Good pronunciation is asthma. Bronchitis, chronic bronchitis. So patient with a history of severe COPD, severe, we presents with a barrel-shaped chest. Barrel-shaped chest. The physical finding is most likely associated with which of the following? Now see, if you see a chronic smoker, not just 1 or 2 year or 3, 4 years smoking, no, 10, 20, 30 years of smoking, daily smoking around 10, 20, 30, 40 cigarettes or whatever they're smoking. But what happens is, the smokers will develop what? They will develop emphysema. The alveoli will stop working. And what will happen? Listen to me carefully. When the alveoli stop to work, then when they try to expire during exhalation, there's always some air inside the lungs that is left. Normally, we all have the residual volume, but in these patients, there's more of residual volume. So lungs is always filled with much amount of air. So if you see them, they need accessory muscles of respiration. If you see a patient of a chronic smoker, you can see his pursed lips. You can see in the diagrams also in your textbooks, beautifully given diagram. Because he will be holding something and then he'll be like gasping like this. He needs more of air inside. Typical, if you see a couple of patients like this, a chronic smoker, you will definitely recognize like that. What happens is their rib cage, they needs it, because it's not functioning. The lungs are not able to function. It is not able to export out all the residual volume or the whatever air in tidal volume normally we exhale out. The air is left hand side. So what it leads to? It leads to expansion of the rib cage. It does not mean that the lungs function better, no, but the lungs need to expand more. So think about it now. Apply common sense. In a barrel-shaped chest, will there be a AP diameter? Will it be decreased or will it be there will be increase of AP diameter? Think about it. Or there will be scoliosis, is bending of the vertebral column. And pectus excavatum is again, the sternum. There's a congenital problem of the sternum basically. What will be there? So basically, what I'm trying to say is you can rule out option number C and D, last two options. We are left with the upper two options: increase or decrease AP diameter. You need more volume, so you need increased AP diameter. Answer will be what? Answer will be increased AP diameter. Need more of the space inside the lungs. Need increased AP diameter. Let me show you an image over here. Then you will understand it in a better way. Think about it over here. Okay. So it's a normal chest, and you can see the barrel-shaped chest. Okay, so which diameter is increased? You can see the AP diameter is the one that has been increased. Plus, if you just look at the anatomy of the rib cage, these are the ribs, right? Behind you the vertebrae, anterior the sternum. So sternum and the vertebrae, they will be remaining there only. It is the ribs direction which will change. Now suppose look at my 4 and 4 fingers on the right and left side, right? Total 8 fingers. If I need to increase the diameter, what can I do? Can I expand it out like this? Can I increase the transverse diameter? Is that possible? No. Because if I remove the ribs like this, if I increase the diameter, transverse diameter like this, the ribs will be breaking away from the attachment of the sternum as well as vertebrae. But if I increase them in an AP direction, you're getting a point, then it is possibility that the distance of sternum and vertebrae might increase, but the ribs can go like this. AP diameter is increased in barrel-shaped chest. A very good question, and we should know this. Okay, let us see the next one. Come to the abdomen part now. Okay, let's see the abdomen part now. Patient presents with severe right lower quadrant abdominal pain, nausea, and fever. Which anatomical landmark is used to identify the location of the appendix? So basically, the question is actually the second line. Which anatomical landmark is used to identify the location of the appendix? First line was just to give you a clinical sort of scenario. So we have options McBurney's, Murphy's, Hasselbeck's, and Lenz point. Answer over here we should know is our McBurney's point. Answer is what? McBurney's point. What is McBurney's point? What is McBurney's? McBurney's point is if you take two landmarks, and one of them will be anterior superior iliac spine, and one of them will be, say, umbilicus. And if you connect them, what right side anterior superior iliac spine? So let me write over here A, S, I, and S. Right side anterior superior iliac spine of the right side, okay? And this is the U for umbilicus. We join them with the line, and then you take a point over here, which is junction of lateral 1/3 and medial 2/3. Lateral 1/3 only and medial 2/3. This roughly tells us the base of the appendix. That is our McBurney's point. But remember, the option number D, Lenz point, is very much similar to it. So it is mainly involved in the surgery, giving a transfer incision or going through the same incision. Answer over here will be McBurney's point. But if you look at the other two options as well, Murphy's point. Murphy's point is basically right upper quadrant. You know, there's gallbladder disease and all. Then we use a Murphy's law and Murphy's point. Hasselbeck's triangle is for the inguinal hernias. Okay. When there is a direct inguinal hernia, it will only come through the boundaries of Hasselbeck's triangle. Now, there's a question for you guys. If you are listening, answer in the comment box. But don't look at your notes or books. Think. Let's see if you are aware of it or not. Tell me the boundaries of Hasselbeck's triangle in the comment box, if you can. Please go ahead. Let us see. It will have a lateral boundary, it will have a medial boundary, it will have a floor as well. And that's very important. A lot of questions are coming nowadays. So Hasselbeck's triangle, homework for you, right? It is also known as inguinal triangle. Fair enough. So the answer over here is McBurney's point. And let us see if we have an image over here. Yes, here we have an image of the McBurney's point, right? So you can see this number 3 is the right superior iliac spine. Right? Anterior superior iliac spine, ASIS. 2 number is umbilicus. You can see number 1 point over here is actually junction of the lateral 1/3 and medial 2/3. This roughly tells us the position of the base of the appendix. That is the point. Okay, here we come to the question. A patient is diagnosed with inguinal hernia. They are not saying direct or indirect, but just inguinal hernia. Which structure forms the inferior border of inguinal canal? So this they are asking the core anatomy question that, okay, inguinal canal boundaries, do you know the inferior border, or you can say the base, or you can say whatever, the floor of the inguinal canal. What is the floor of the inguinal canal? Is it inguinal ligament? Is it trans abdominis muscle, rectus abdominis muscle, or internal oblique muscle? So B, C, and D options are what? They are the muscles. They are the muscles. What do they do? The rectus abdominis muscle is in the middle line. Transverse and internal oblique are on the lateral side, anterolateral aspect. The rectus abdominis muscle has nothing to do with inguinal canal. So you can omit option number C. B and D option, they form what? They basically form a bit of anterior wall and the roof of the inguinal canal. You'll see in image. It is the inguinal ligament, the Poppert's ligament, that forms the floor of the canal. Let us see over here. Look at this image. Okay, now have a look. This is the right side inguinal canal. Where is the canal? This hole is the canal. Can you see this spermatic cord coming out? This hole is the canal. Okay, now have a look. This is the inguinal ligament. So it's a ligament. It's basically nothing, but it is actually a tendon of the external oblique muscle. Okay, or you can say the inferior aponeurotic fibers of external oblique muscle, which gives rise to inguinal ligament. So it supports the inguinal canal from below. That is the answer. This is the floor of inguinal canal. So you can see the canal, the floor below is the inguinal ligament. Now this will be the 2 muscles over here, which are those internal oblique. Can you see over here? and this is the transabdominis. What are they forming? They are forming a bit of anterior wall, mainly the interoblique, and then they both go and cross over the canal, forming the roof of the canal. And then they both form the tendon known as conjoint tendon that goes medially. Okay, rectus abdominis is where this is the rectus abdominis muscle. It's actually coming up like this. It's a vertical straight muscle. This is your rectus abdominis muscle over here. So floor is inguinal ligament. What is inguinal ligament? As I told, it is nothing but a inferior most aponeurotic fibers of external oblique. Therefore, when we say this is inguinal ligament, this is exactly our external oblique aponeurotic muscles on. What is aponeurosis? It is a flattened tendon, right? So this is external oblique and inguinal ligament. This is internal oblique and transabdominis, forming mainly the roof. Rectus abdominis right over here. Tomorrow they ask you what is the posterior boundary of inguinal canal. You will have to go with the answer of fascia transversalis. Okay, so let us write a couple of things over here. In this particular question, the answer is inguinal ligament. And transabdominis, it forms, so option number B, let us write a roof. Same internal oblique, it is forming the roof. Option number C is not forming anything. So tomorrow they ask, okay, any structure forming the posterior boundary, tell them yes, it is F dot T, fascia transversalis, posterior wall of the inguinal canal. And why is this so important? Why I'm stressing so much over here? Because see, inguinal hernias, you all must have heard about it. And the moment you start to go to surgery, OPD or wards, you will see there are a lot of cases, either of hernias and hernias and hernias, or you also see a lot of gallbladder, hydrocele, a lot of common cases like this. Then other cases are also there, but yeah, these are the common cases. Okay. So now let us see the next question over here. Okay. A patient with a history of alcohol abuse presents with a severe epigastric pain and is diagnosed with pancreatitis, inflammation of the pancreas. It's a very, this very critical situation. Pancreatitis is not an easy thing. There's a good mortality rate as well. And the two important causes of pancreatitis is one is this alcohol, second is gallbladder stones. The two important causes of pancreatitis are number one, alcohol abuse, second is gallbladder stones. Which vertebral level is the pancreas most likely associated with? That is the question. Now, sir, what is the use of it? See, I tell every time in my lectures that nowadays CT scans are so common. If you're looking at a CT scan and forget about CT, for your practical purposes, it is important. But understand, questions come like this. The question come in your NEET PG exams, your INI CT, whatever exams you're going to give in your future, next, whatever it is. Questions will come off like this. So now they're asking us the vertebral level of pancreas, simple as that. In other words, they can give you a CT image and they can ask you, okay, which structure is this, or where is pancreas? A, B, C, D. Which one is pancreas? Therefore, now, if you look over here, the image below, forget about the options for a second. This yellow color is the pancreas over here. This is what? This is the duodenum. So here you will have the transpyloric plane, pylorus. So this is the transpyloric plane, L1. So right at the region of L1, a bit of say T12 also, and uncinate process will be around L2, no doubt about it. But yeah, mainly this pancreas bulk is in the L1 region. If you look at the options, T8, T9, rule them out. T12, L1, yes, very good option. T12, L1, very good option. L2, L3 in again. L2, a bit of L2 you can see over, but L3 will be a bit below. So L2, L3 rule out, L4, L5 rule out. Answer is your T12, L1. Answer is T12, L1. Let us highlight this answer over here. Okay, so questions are coming like this. T12 and L1, T12 and L1. This is the point. So if you just do make a horizontal line over here, it involves maximum of the pancreas. T12. Okay. Okay, let us see one more beautiful question over here. Okay. A patient with a stab wound to the abdomen, is found to have a laceration of the liver. Which rib levels are most likely to be associated with this injury? A bit of a tricky question is what is the word I should be using for this particular question. Tricky question. Why? They are saying there's a stab injury to the abdomen with a laceration of the liver. Which rib level? See, liver is a huge organ. It starts from around say 5th or 6th rib, goes down till 6th, 7th, 8th, 9th, 10th rib, it goes down. It is a huge level. Height on the right side, huge vertical extent. Right, it is 1.5 kg organ. It is not a small organ. So what will be the answer? A, B, or C? The tricky question, the tricky part over here is they're only mentioning of the laceration of the liver. They are not saying laceration of the pleura or the lungs or any other structure. They are only referring to liver. So here's a catch that we can take over here. And let us see with the help of the diagram. Let us understand from the diagram first of all. Okay, here is the diagram. Okay. Now see over here, this is the liver. As I told, it starts from rib number 5 over here. So this will be the rib number 5. Okay, just below rib number 5 and 6, 7, 8, 9, 10. This whole is liver. And not just on the right side, it even goes on the left side as well. This whole is liver. Now, it can be injured in rib number 6 and 7 and 8 and 9 and 10. But which answer to choose? You have to choose one answer only. The point over here is if the injury is at rib number 6 or 7 or 8, it will first include the pleura and lungs, then the liver will come. Why? Because in the mid-axillary plane, till rib number 8 or 9, we have the lungs and pleura. In the mid-axillary plane. In the mid-clavicular, until rib number 6 to 8, we have the pleura. Let me repeat again. In the mid-clavicular plane, till rib number 6, we have the lungs. Till rib number 8, we may have the pleural cavity. In the mid-axillary plane, till 8th rib, we might have the lungs, the inferior part of the lungs. And 9th and below maybe 10th also, we can have the pleura. Therefore, if you have to choose only for the liver, you have to go a bit lower down, 9th, 10th, 11th, like this. And this will tell us the answer. Therefore, the answer will be what? Answer will be over here. Just a second. Yes. We'll look at the options. Answer will be our option number C. We can't go with the option number D, 11th and 12th, because the floating is present posteriorly. Answer is option number C over here. Tricky question I told in the beginning. And therefore, a tricky answer will only do over here. The answer will be our option number C, ribs 9 and 11. Okay. Got the point? So remember this part. Okay, let us see a couple of questions of pelvis as well. A patient with pelvic trauma is found to have an injury of the sacroiliac joint. Sacroiliac joint, where is sacrum? It's a lower part of the vertebral column. Below lumbar vertebrae of the sacrum. And here is the sacroiliac joint. Why? Because the weight is transmitted from sacrum to iliac. That is the sacrum to hip bone. That is the region of sacroiliac joint. So, injury to sacroiliac joint, which ligament is most likely involved in stabilizing this joint? So, which ligament will be there? Sacroiliac ligament. But if there is any option like sacroiliac ligament, no. See, sacrum and ilium, two bones, joint. Which ligament? Sacroiliac ligament. There is anterior sacroiliac, posterior sacroiliac, and intraosseous sacroiliac ligament. Quite strong ligaments, but none of them is in the option. What to choose now? Then you have to apply your mind now, brains now. Let us see the options. Iliofemoral. This ligament over here, iliofemoral, is found at the hip joint. So rule out option number A. Sacrotuberous. It is from sacrum to the ischial tuberosity. Is it close to the sacroiliac joint? We'll see in the image. Inguinal ligament. We just learned about it. It is what? External oblique aponeurotic fibers. The inferior edge. Pubofemoral. Again, it's a ligament of the hip joint. Right? So A and D rule out, even C also rule out. What we are left with option number B only. It is sacrotuberous. Let us see with an image. Okay, let us first of all highlight this. We know, okay, this is the answer, and let us confirm it by looking at the image over here. Okay. This is a posterior view of the whole sacrum plus the hip bone over here. So here you're looking at a sacrum. Okay, this is the hip bone. This is the sacroiliac joint over here. Which joint is this? This is sacroiliac joint. Weight is transmitted from sacrum to hip bone on both the sides like this. And here you have what? This is your ischial tuberosity, where the hamstrings are attached. This is the sacrotuberous ligament. So in a way, this ligament is supporting the sacrum. So obviously it will both, because it's on both sides. So it is indirectly supporting the sacroiliac joint as well. Second ligament associated with sacrum is sacrospinous ligament. This is sacrum to ischial spine over here. You see sacrospinous ligament, sacrospinous. Outside is sacrotuberous and deep to it is sacrospinous. Can you name a muscle attached to sacrotuberous ligament in the comment box, guys? Up to you. Is there any muscle which is attached to sacrotuberous ligament? I'll give you a hint. You're looking at a posterior view. So which region is over here? This is a whole gluteal region. It's a big hint. So I name the muscle attached to sacrotuberous ligament. Homework for you. Okay, answer in the comment box. Okay, let us see the next question over here. Okay, another beautiful question. During childbirth, a woman suffers separation of the pubic symphysis. Now, this might happen. So during normal delivery, the baby is passing through the birth canal. So all the ligaments are loose and bones are actually expanding because the head has to pass out. Just think about it. Just merely thinking of the process of childbirth might give you some mental pain. Okay, so much is happening inside the body. Just think about it. So there can be separation of pubic symphysis, as the question says, which muscles are attached to pubic symphysis. In a way, anatomically, they are asking, okay, can you think of any muscles attached to pubic symphysis? Options are rectus abdominis, adductor longus, internal oblique, sartorius, external oblique, pectineus, trans abdominis, and gracilis. Now, see, rectus abdominis present in the midline. It goes down, definitely attaches to pubic symphysis, without a doubt. And pubic symphysis is what? It is a part of pubic bone. And the pubic bone, mainly the inferior rami, right? And a bit of anterior rami as well, they also give rise to a lot of medial compartment of thigh muscle. That is the adductor muscles. So option number A looks good, but let us see other options. Internal oblique and sartorius. See, internal oblique muscle is actually coming from the iliac spine, or you can say the iliac crest, as well as the rib cage. Then they're ascending up and medially, and then they form the linea alba and all. But they're not attached to the pubic symphysis. Same goes with the external oblique. External oblique inferior fibers might reach pubic tubercle, forming the inguinal ligament. They don't per se go fit to the pubic symphysis. And pectineus again, it is very close to the pubic symphysis. Transverse abdominis again. Answer over there will be option number A, rectus abdominis and adductor longus. Let us see it with an example of a image is here only itself. Have a look at the image. This is the pubic symphysis over here. This is the rectus abdominis muscle coming from, actually it is going from pubic symphysis or pubic crest above into the lower ribs. The rectus abdominis is definitely attached. And you can see this adductor longus muscle, right? Going to the medial compartment thigh. So option number A will be our answer for this particular question. It is rectus abdominis and adductor longus will be our answer. Okay. Okay. Let us see one more question. I hope you guys are not getting bored. Okay. I hope you enjoy the MCQ session. MCQs are there to test your knowledge, right? And it gives you a different perspective. Okay, that question will come like this. It's the end result of all of your hard work. A patient presents with pain radiating down the back of the leg, which is exacerbated by sitting and relieved by standing. This presentation is most consistent with which condition? See, pain going to the back of the leg, through the hips, back of thigh and back, it is sciatic pain normally. Unless and until proved otherwise, normally it is sciatic pain. There's a catch which is exacerbated, means increased by sitting. When we sit, we are flexing the hip joint. So there's more stretching of the sciatic nerve. Yes or no? Because sciatic nerve is present in the buttock region. When you're sitting, you're flexing the hip joint. Obviously, the buttock region is being stretched and relieved by standing. Let us see the options. Now, presentation is most consistent with which condition? Okay, let us see the options over here. Okay. Sacroiliac joint dysfunction, sciatica is the answer. Hip osteoarthritis, piriformis. Piriformis syndrome. See, piriformis syndrome, the sciatic nerve runs just below the piriformis muscle, right? Piriformis syndrome is again compression of sciatic nerve, but in those cases where the sciatic nerve is passing through the piriformis muscle, not below the piriformis muscle. So what will happen that whenever you contract the piriformis muscle is basically doing your lateral rotation. They are the small lateral rotators. So whenever you do a lateral rotation of the thigh, as the sciatic nerve is passing through the piriformis, there can be some compression of the sciatic nerve. But there the story was different, sitting and standing. It was a typical case of sciatica or sciatic nerve injury. Okay, that is the sciatica over here. Hip osteoarthritis, sacroiliac joint dysfunction, there's nothing to do with this. Let us see one more last question of the day. A patient with a pelvic inflammatory disease known as PID is found to have a tubo-ovarian abscess. That is, abscess is the correction of pus. Tube means fallopian tube and ovary. Collectively over there, you have a patient having a PID. Which ligament contains the ovarian artery and vein? Is a simple question. Before going to this question and answer, again, last work for you guys. If possible, in the comment box, do tell all of us, ovarian artery is a branch of which artery? Okay. And the answer will support over here of this question. It is coming from above. The ovarian artery is coming from above. You have to tell it is a branch of which artery. Here they ask me which ligament contains it. The answer is suspensory ligament of the ovary. And if you look at the image over here, okay, this is the uterus. This is the fallopian tube, around 10 centimeter. The fimbrias, this is the ovary over here. You can see this ligament, also known as infundibulopelvic. This is a suspensory ligament. It is containing the ovarian vessels. Answer over is suspensory ligament. Let us look at the other options. Now see, from ovary to the corner of the uterus, right? You have the ovarian ligament. What is this ligament? Ovarian ligament. And from the corner of the uterus, going to the inguinal canal is the round ligament of uterus. So both of this ovarian ligament and round ligament of uterus, listen to my words very carefully. Both of this ovarian ligament over here and the round ligament of uterus, they are the remnants of gubernaculum. They're different. Question they ask is about the ovarian vessels. It is in this ligament, suspensory ligament. I gave you one more name. Infundibulopelvic ligament is the other name of suspensory ligament. What is this cardinal ligament, sir? Then cardinal ligament is nothing but a transverse cervical ligament. It is one of the supports of uterus. It is over here at the cervix, transversely going. That is your cardinal ligament, McEnroe's ligament. So what is the answer over here? Answer over here is your suspensory ligament of the ovary. Above answer was shared. And this suspensory ligament is this over here. What I asked you guys, tell me ovarian artery is a branch of which artery? Simple as that. Okay. So these are all the MCQs. I hope you enjoyed it. Thanks for watching and do follow our social media handles. Any queries in the comment box, do reach out to us. That's all from my side. See you in another interesting session. Till then, bye-bye. Take care and good night. Thank you.